at the end. So the third part I'm going to look at is sexual health, and this is going to be a broad overview of lots of different aspects of it. So I'm not going to cover anything in detail, but I'm going to show you where to go and find stuff. And sexual health is, this is the WHO definition, looks at physical, emotional, mental, and social well-being in relation to sexuality and not merely the absence of disease. So it's similar to our definition of health in general. So how prevalent is sexual health problems? And we're going to get very South African now because we want to know what's happening in South Africa. And of course, it depends on how you define a sexual health problem, which we won't get into, but the bit of studies that we have from a systematic review that was done of South African research is that about 40 or 45% of women consider themselves as having a sexual problem, and about 20 to 30% in men, with the prevalence lying higher within older people. But less than 20% of those will actually seek assistance from healthcare providers. And only 9% actually reported being even asked about their sexual health. So the topic just doesn't come up, so to speak. Now, what's interesting is if you want to ask, well, what defines a sexual dysfunction? The thing that comes up in all the studies and very strongly in the DSM-V is the word sexual distress. So it doesn't matter what your relationship is around sexual pleasure or any of those things. The question is, does it cause you distress? If it doesn't cause you distress, then it's fine. If it causes you distress, now we can start looking at a dysfunction. So this is not a great definition, and it shows how unclear we are about what we mean with sexual dysfunction and how to define it. So how much research do we have about sexual dysfunction in South Africa? Not very much at all. There are a total of 18 studies that's looked specifically at sexual dysfunction. You can see some, and the ones on men are all about erectile dysfunction. There's a few on female sexual dysfunction. And then there's some articles looking at various comorbid diseases and sexual dysfunction. So for those of you looking for a research topic, there's a huge field here waiting to be explored, and very easy to find people who have sex if you want to include them in your studies. So what happens in sexual health, and this is an interesting word that gets used a lot also at the WAS conference, is the word de-pathologizing sexual pleasure. So what used to happen is that we had sexual pleasure, and then we had sexual rights that said, no, well, you're not allowed to do this and you're not allowed to do that. And then what we did in medicine is if you weren't allowed to do it, it also became a pathology. So for example, up until 1973, homosexuality was considered a disorder in the DSM, and it was finally removed. But still, right up into the DSM-IV, we had something called gender identification disorder. So that means that people who were assigned, for example, male at birth, but identified as women, was considered to have a disorder, a mental health disorder. It was in the psychiatric textbook. That's been changed. Note, for those of you that don't read the DSM-V over your weekends for fun. So in 2013, that term was taken out. And the term they now have is called gender dysphoria, which has to do about the distress caused by somebody who was, for example, assigned one sex at birth and identifies with a different gender, and what that experience is. And that you can use then as a way to discuss transition and things like that. So the other one that had to really do some work on this was the WHO, and that's, of course, our famous ICD-10 coding. So until 1992, homosexuality was still listed as a diagnosis in the WHO. And also the ICD-10 had something called gender identity disorder. So the ICD-11 has now been published in 18 June 2018, and the term was changed to gender incongruence, which is similar to the DSM of somebody who experiences, it's just a description of somebody that experiences this different identity than the one they were assigned at birth. And you might use that if somebody's going, for example, for transition or gender affirming surgery, then you would use that as the ICD-10 code for the insurance, I guess, in America. And what's very important is the WHO ruled specifically then at their assembly in 2019 that being a trans or gender diverse person does not mean that you're suffering a mental or psychiatric disorder. So that's been a huge and important step in medicine, is that we stop pathologizing what is just considered part of normal variations of human diversity. So now when we want to look at sexual dysfunctions, it's a very short list. So it's mostly based around the DSM still. So male sexual dysfunction, this was a nice article in the SAMJ. You get disorders of erection, you get disorders of ejaculation, and you get disorders of desire arousal. And again, the desire arousal gets interesting because that definition is still set on that original spontaneous eroticism definition of what we think desire is supposed to be. Female sexual dysfunction you only really find in the DSM-5. There's female orgasmic disorder, female sexual interest arousal disorder, and massive, that's the only one that's still quite controversial, because according to that, no sexual fantasies, no initiation of sex, all of that are some of the lines to be qualified as having female sexual interest or arousal disorder. And we consider that now may just be women who have responsive sexual desire. And then genitopelvic pain or penetration disorder, this includes vaginismus, for example. So the way DSM-5 works is that they have these names of these sexual dysfunctions, and then you just need to make sure that it's not related to a non-sexual mental disorder, so maybe as a result of depression, that it's not due to substance abuse, that it's not due to a medical condition, that it's not due to severe relationship distress or partner violence or things like that. It must be longer than 6 months. And again, it must cause sexual distress. So if you meet all the criteria for sexual arousal disinterest disorder, but it's not causing you distress, then you don't have a disorder. So again, it's not the most helpful of methodologies when you're trying to assist a patient. I've got a few slides on just male sexual dysfunction and then female sexual dysfunction. So how many men actually experience sexual dysfunction in their lifetime? About 30%, depending on the studies. But it gets quite alarming when you look at, for example, men with diabetes or cardiovascular disease. In one study, 50 to 70% will have erectile dysfunction eventually, and a third of diabetic men already having erectile dysfunction at diagnosis. And very important, there's actually the only studies there's a lot written around erectile dysfunction as one of your, and it's linked to cardiovascular disease. So having erectile dysfunction is also a sign that there's issues, that there's, in terms of your risk assessment with cardiovascular disease, and having cardiovascular disease puts you at higher risk of erectile dysfunction, similar to having chronic kidney disease or retinopathy or etc. So very important that they have similar risk factors. And so a large part of erectile dysfunction in men means triggering a conversation around cardiovascular risk. So if you go to the EML and you look up sexual dysfunction, you find half a page on erectile dysfunction. There's nothing else in there. You can cross-refer to anti-androgenic disorder because that can cause erectile dysfunction. But basically, it's just one little section, and it's not very detailed. Basically, you just examine your patient properly. You make sure there's no androgen deficiency in your examination. If you suspect, you can do a testosterone level. You review all the medicines to make sure it's not interfering, and you ask about substance abuse, obviously. And then you identify and treat all those cardiovascular risk factors we talked about. And obviously, lifestyle modification is part of that. And that's pretty much it. You can obviously try and treat the underlying condition if there's a specific condition that contributes. And if you've got cardiovascular risk like diabetes and hypertension, bringing those under better control certainly does help. And you can only use testosterone, only makes a difference if they actually have a proven testosterone deficiency or androgen deficiency. You can go and look that up in the EML, but that's a very small percentage of our men. And of course, the big challenge is how to now differentiate it from what we call psychogenic erectile dysfunction. And of course, the big problem is that the biggest thing that drives psychogenic erectile dysfunction is performance anxiety and fear of failure on a variety of levels. So if there's fear involved, not good for erections. And so, of course, if somebody's got a physical cause that might have been triggering poorer performance, then you might have an issue later with then being terrified that it will happen again, and that just creates a vicious cycle. So that does make it more complicated. So there are 3 potent selective PDE5 inhibitors that we can use once you've done all your factors. I'm not going to cover this in detail. Please go and look it up before you decide to prescribe it. Tablet you take before sex, and very important, you must get sexually stimulated or the tablet doesn't work. And it takes about 30 to 60 minutes, depending on what you've eaten. And we don't have it on the public sector, or not in the Eastern Cape. And it's amazing to look at the price differences on the internet I'm not sure all of that is the real thing. But female sexual dysfunction is much more broad in terms of management, in terms of what we know. We've spoken about all these different functions that might interact. And we've already spoken about the fact that what causes sexual dysfunction and what's causing sexual distress might be a perfectly within the normal framework of sexual pleasure behavior for that particular woman. And it's the expectations that's causing the problem. But we have to be able to look at chronic illnesses that might be interfering and need to talk about aging and menopause and all of those things and how it affects sexual responsiveness. And doesn't necessarily decrease. It can go all kinds of different directions and sexuality can just change. I'm not going to go through this. There's a nice article on sexual dysfunction in women that looks specifically at some of the medical conditions that might worsen it. And I think what we're not very good at is asking. So if you've got patients with hypertension, hypothyroidism, Parkinson's disease, renal failure, how often do we actually have a conversation around sexual, how they're experiencing their sexual health? And then just always remember to check your medicines, your SSRIs and your hormonal treatment, your top culprits. But so we do have a little exciting announcement, which is to do with our sexual health in our diverse populations. So we've had a challenge in looking at some of our diverse populations and our diverse sexual orientations and our gender identification population. We've identified them as key populations. So these are key populations that are at higher risk, mainly because they're not accessing services. So SOGI, that's sexual orientation, gender identity diversity, there's huge health disparities. So there's higher substance use, there's higher violence and victimization, there's less access to sexual and reproductive health. So for example, in one study, 49% HIV incidence in trans women. And so the question is, how do we help these populations? So a major concern has been that these patients are out there, they're not getting help, they're not accessing help, and a huge amount of mental health issues, usually secondary to the distress caused by not being affirmed or not being supported or not being accepted because of their gender diversity or because of their sexual orientation. And so a big emphasis has been about how do we create services that are inclusive and will allow all of our patients to access healthcare. So this was in a big, huge study done in Africa and included South Africa as well, to look at access of healthcare in relating specifically to sexual orientation and gender identity and expression in South Africa. And when they talked to healthcare workers, some of it was a little bit worrying. This is in 29, and that Muller is not me. There was a lot of people treated with less respect. They experienced being actually called names and being insulted by a healthcare worker, almost 48%. And then actually 39% of people denied healthcare because of their sexual orientation or their gender identity. So one of the ways of helping our transgender population is to look at gender affirmation as a pathway to improve health. And we want to improve their mental health, we want to improve their physical health, and we want to improve their sexual health. And there's more than enough research now that shows that gender affirmation actually provides a massive ability to help people access services. So with gender affirmation, I talk specifically, there's different aspects. I'm going to talk a little bit about the medical side, but there's four domains that we want to look at. There's a social domain. So calling the person, for example, by the name that they have chosen, that they identify with, using the correct pronouns. If you don't know about pronouns, ask your teenagers, go and look it up. Important and being able to ask people, what pronoun do you want me to use? And to be accepting and of the gender presentation, the way that they are expressing themselves. Being able to create psychology services, mental health services for these patients. And then of course, there's all the legal ramifications around identity and how their sexual rights. But I want to just focus on the medical side of it. Because in gender affirmation in the medical domain has got a lot to do with what happens in sexual health. So that's looking, for example, at their reproductive options, looking at trans-competent primary and preventative health care, so understanding the sexual health needs of those populations, but also includes gender-affirming therapy, including hormones, surgery, etc., etc. So I'm now going to do the drum roll. What we have just had released by the South African HIV Clinician Society is in South Africa, a guideline specifically on affirming gender-affirming healthcare guideline for South Africa. And you can see at the bottom here talking about evidence-informed best practice recommendations to enable South African healthcare providers to offer quality affirming services to TGD clients. So this is very exciting. There's a nice shortened version for people who want to get an overview. For those of you that are curious and interested to actually start services like that in your sexual health scenarios, there's actually a much more detailed guideline. And at the moment, a lot of the gender affirming services is happening through NGOs, but quite often in conjunction with Department of Health. And the Department of Health is starting to look at how to create access to gender affirming services. So for example, in East London, we have a CHC, Duncan Village Day Hospital, where its RHI has set up a gender affirming services, and we have about 18 people currently on treatment there. And we're looking more and more at how to create access for transgender people. The biggest thing that this, for us from a medical point of view, from a boring, dry, doctor-centered approach, is that we want people to be able, when they access gender affirming services, they also access PrEP and HIV testing and contraception, and be able to create a whole sexual health package. And there's much better engagement with services if we put it within a package that's affirming to our patients. So I'm not going to discuss the guideline at all, but just to realize that not all transgender people necessarily need to be affirmed in the same way. It's also a very long process, and there are very clear standard of care guidelines created by the World Professional Association for Gender Health. So it's not an ad hoc thing, with very clear guides on how to approach this process, looking both at hormonal therapy and surgery. And what's important is that research show that the treatment is very effective and also leads to improvement, not only in sexual health, but also in mental health of our patients. So this is an ethics presentation. So I have quick thing going through our ethical principles. So looking at all that we've learned about gender diversity and affirmation, we can see that creating this guideline is a respect for the autonomy of our patients. It helps to reduce stigmatization and exclusion on the grounds of gender diversity, which has led to a lot of harm in the past. Obviously, gender information, we know, improves health outcomes. And justice is back to our sexual rights, to give our patient the right to access to care, regardless of their orientation. So I've got they always have knowledge, attitude, skills, right? So it's called attitude. I don't really like the word attitude, but it's always good to address the elephant in the room. So as doctors, we have our own cultural, religious, and particular perspectives on sex, sexual orientation, gender diversity, and these may not be the same as our patients. And I think from that study that I mentioned earlier, and I have found that much more prominent even with our doctors, when I speak to junior doctors, for example, or medical students that's coming through, I really think that as clinicians, we have this superpower where we can stand strongly within our own perspectives, and yet we can be accepting and affirming of another's choices. And we already see this in South Africa. I think there's been so many, whether it's been women's rights, or whether it's been firstly around race, or whether it's been to do around socioeconomic status, different cultural ideas, different cultural beliefs, different religions. It's extraordinary, whereas healthcare providers, we can have this ability that you don't have to feel that you compromise whatever your own values or ideas are, and yet you can still provide services for our very, very, very sexually diverse population in South Africa. And I think we're very good at that, actually. And I think it's a battle. What I've found interesting is that you sometimes find that doctors can do this quite easily in the consulting room, but it becomes more a challenge when it comes home. So if it's your own teenage child who is suddenly coming out different than what your values are within your particular culture, then that gets more difficult to navigate. But I think with patients, we've already been practicing for the last few decades on how to be embracing for all our different choices. But interestingly, although we always think that religion is almost on the one side, and then we have all our orientation diversities on the other side, that's not actually the true and not needing to be the case. And there's some amazing organizations looking specifically, inclusive organizations providing spiritual care and religious care for regardless of your sexual orientation or gender identity. The Al-Fitra Foundation, or used to be known as the Inner Circle, specifically for our Muslim populations. And then a great website that you can look at to refer patients to who are struggling, I Am, which is it's called the Inclusive and Affirming Ministries. And they've brought out lots of amazing publications. For example, they've got something called The Bible and Homosexuality, a toolkit, which is about finding ways for people who want to stay within their religion and finding a way to bring these different worlds together. So I've got 2 more slides and then we're done. Because we have to talk about sex, right? We have to have some skills stuff right at the end. And I think one of the things that's more important is not even what you necessarily say, but just start saying something. So we don't talk about sex. And in one survey, this was a global European survey, 60% of men believe that their doctor should initiate inquiries about sexual health. And we actually can have opportunities to bring up the topic in all kinds of cases. So when you've got an aging patient, you should probably ask. If you've got a key population, you should definitely ask. If you've got an adolescent, you should definitely ask. And of course, now patients with chronic diseases. So there's actually lots of scenarios where the patient would appreciate the doctor bringing up the topic. And if they're not having a problem, then obviously they'll just say so. Women are more likely to raise the topic, but they might come in and ding on the side. And most of the times you actually need to bring it up, and you need to gain a little bit of confidence in talking about sexual health and sexual pleasure to know about some of the distress that our patients may or may not be in. So the next patient that you see with an STI, let's just start very simply, right? So you all know this question, it's on the top of your syndromic treatment guideline. Have you had sex in the last 3 months? Do you have sex with men or women or both? How many partners have you had in the past 12 months? And depending if it's men or women, you will ask, well, how many male partners have you had? How many female partners have you had? So you'll obviously adapt it. And you need to be able to ask these questions, which shows that you are extremely comfortable with whatever they're going to answer, to be able to open up this conversation. If you're not sure regards gender expression or what pronouns they might want to use or what gender they identify at, ask. What gender do you identify with? And if you have that lovely gender jabu, you can even use that to open a conversation. And if you want to take your sexual health history to the next level, you can ask, do you enjoy sex? Question I often ask, do you ever have sex when you don't feel like it? So that opens a whole conversation. So only ask it when you're ready. How often do you feel like having sex or have fantasies about having sex if you want to start talking about desire? And what is the best part for you, the cuddling or the sex? I mean, all of that is being able to open the conversation to then talk about this wide spectrum of sexual desire. So at the WAS conference, this was Esben Esther Pirelli Benestad, an extraordinary Norwegian physician and sexologist, one of the very famous transgender women in Norway, who's done extraordinary work in terms of transgender rights in Norway. He's published an incredible amount of research and was one of the golden medal presenters at the WAS conference. And she loves bringing poetry. And I screenshot this, but I'm not sure if she wrote it or if she just found it. I assume she writes. Her presentations are absolutely extraordinary. It's like watching a work of art, but embedded with very solid medical evidence. So I'll just quickly read that to complete the session. So disease. They call it a disease. Then what is ease and who decides? They call it a disorder. They call I a disorder. Then what is order and who decides? This we have thoroughly understood. You shall not feel bad for what you sense as good. So that's just to bring us to a close. Thank you very much for attending. We are going to open it into discussion now. As you can see, I've got millions of references, and I'm very happy to make my slides available. I'm always very happy for information to be spread. And all of this will be recorded as well and made available in the 3 different parts. I'll edit the last discussion out, but I'm going to keep recording the last discussion, but it won't be made public because it's good to create some